All right. Hello, everyone. This is the review for test two. So this test is going to go over lab value, part one and two, hemodynamics and shock. This review, I'm just going to go over lab values two and onwards. I know you guys already started lab value one. I think it was your second week, so I'm sure you've been studying it for a while. If you have any questions on the material, please feel free to reach out to McKenna or I. So let's get into it. Okay. So fluids and electrolytes, 60% of your body weight is fluid. Most of that is going to be in your intracellular space, um, which I'm sure is probably a review from the fluid shift lecture. There's a large reserve in that space. And the chief extracellular cation is sodium, chief intracellular is potassium. And you just always want to make sure you have a balance. A lot of patients, especially in the ICU, you're doing intake and output. You always want to know whether they're like in a positive fluid balance or negative or static. So you always want to identify the trends. Are they trending up or they trending down as far as weight from fluid goes? Okay, so sodium, if you have low sodium, this is going to cause confusion, nausea, seizures, weight gain, things like that. Weight gain, this is going to have to do with the fluid retention. Um, and to explain this fluid retention, fluid loss, um, this is kind of talking about a dilutional hyponatremia or a hypernatremia when it's used in comparison to the liters of fluid. So it's measured in milliequivalents per liter. And so I was talking with a student about this, and just think about it like if you have normal concentration of like some hot chocolate or something, and then if you just dump a ton of water in it, like yeah, there might be still be about the same level of like cocoa, but it's not going to taste as much like chocolate, nearly as much, because there's so much fluid that's diluting it. The same principle with sodium, it's not going to be able to do its job as much if there's so much fluid that's diluting it. So confusion, nausea, seizure. Um, if you have low sodium, that means you're going to be have less osmolarity in the fluid because sodium is a major driver of your osmolarity. And so think about the whole hypotonic shift. If your blood vessels have hypotonic fluid in them, it's going to shift into the brain cells, cause that cerebral edema, and lead to things such as confusion and seizures and weight gain. That's the extra fluid. We already mentioned that. Sorry, it's been a long day. Okay, hypernatremia. So thirst, dry mucosa, anxiety, think about those are all symptoms of a fluid loss. So if you have less fluid, you're going to be dehydrated. Okay. So potassium is the major intracellular cation. So this is cardiac and muscle function. I'm sure that's been drilled into you by now. So if you have less potassium, you're going to have that muscle weakness and hypoactive reflexes. So watch out for the digoxin toxicity. Digoxin isn't used too much anymore, but like potassium and that digoxin have that inverse relationship. I don't know if you remember from farm. So if you have low potassium, it puts your body at a higher risk for that digoxin, and vice versa. If you have high potassium, then your digoxin won't be as likely to be in that therapeutic range. So if you have high potassium, you're going to have more of that depolarization of the nerves affecting your muscles. So that's going to lead to things like ventricular arrhythmias, weakness, and acidosis. If you remember, um, you have the hydrogen and potassium exchange that happens both in your cells and in your kidneys. So if you have high potassium, the cation is going to switch for cation. It's going to be driven into the cell, and then hydrogen or protons or acid is going to be driven into the blood vessels. So never push IV potassium, right? That's Dr. Beckstrom talks about how how they sometimes kill prisoners on death row with that method. You're going to cause major cardiac issues. Um, so always diluted um, or given orally, and you want to monitor them with an EKG when they are receiving potassium. Okay, chloride moves it in and out of the red blood cell according to oxygen level in plasma. Um, yeah, it's a little bit of a complicated mechanism. Chloride will exchange for bicarb. Just an easy, simple way to remember this, and one of the ways that this works is that if you have your body is constantly in this state of equilibrium, right? You have even positive, even negative. So if you have more of this negative, more chloride, then you must get rid of some negative, um, or add more positive. But if you were to get rid of negative, you would get rid of the bicarb. And so if you're getting rid of bicarb, you're going to be more likely to be acidotic. Um, And then just reach out if you want to know more about the whole oxygen level in plasma. You can look it up or reach out and talk to me about it. Okay. So slow, shallow respirations, right? If your body um, is in alkalosis because you have low bicarb or you have low chloride holding on to bicarb, then that means you're not going to want to breathe out the CO2. Uh, and then opposite with if you have high chloride. Okay, I think this is a lot of what we just talked about. Um, Yeah, I'll just explain very briefly. So, for example, if the blood is going to your lungs, this is a high oxygen environment. Your blood is going to want to say, okay, time to unload CO2. You have bicarb and you have protons, and together in the red blood cell, they will exchange, go through a chemical reaction, and then create CO2. So, um, then when that happens, the bicarb goes into the cell to create the CO2. Chloride's going to come out. So that's kind of how that works with the whole oxygen CO2 balance. Okay, magnesium, cofactor in ATP use and neuromuscular control. Low magnesium causes tremors, hyperreflexia, seizures. High magnesium, um, nothing too crazy there. Just know chronic alcohol use could be a cause of low magnesium because like alcohol has a lot of calories in it, so you're not going to be eating as much. You could be nutrient deficient. The magnesium containing laxatives, such as milk of magnesia. I can't think of another one off the top of my head, but that's gonna put you at risk for hypermagnesemia. Okay, being and creatinine. So you're gonna be looking at both of these in tandem as far as kidney function works. So if you have high BUN, that will mean that you are either eating a ton of protein because the N in BUN stands for nitrogen and nitrogen's in protein, or you're dehydrated. And so that would increase your BUN. Um, Kind of similar to the whole sodium thing we were talking about because it's measured in milligrams per deciliter of fluid. So dehydrated, it'll raise your level. Creatinine, that is specific to renal function. And then again, you're looking for trends here. You know, like always want to look for trends. Okay, so here we have a lab case. You have a low sodium, low potassium, calcium, magnesium, BUN. Okay, likely causes. What's going on? Prolonged diarrhea. So that's going to cause lots of dehydration, and you're going to see that here with your BUN. Um, you're gonna have that diuretic use, getting rid of a lot of potassium and sodium, poor intake, right? You have a low magnesium here, so you're not eating as much of it as you should, which that could also contribute to the low values of the other electrolytes. So what are you gonna do? Replace with fluids because they're dehydrated. Replace with electrolytes slowly, and you want to monitor their EKG because you're going to be giving them potassium. Okay, hemodynamics, how blood flows through the body. Yeah. Okay. So you have preload. This is ventricular filling. So this is like before blood gets to the heart. Afterload is the resistance. This is after the heart. Contractility, the force with which the heart pumps, heart rate and rhythm, and cardiac output. You guys probably remember all that. So normal cardiac output is 4 to 6 liters, although the more accurate measurement is like cardiac index because it takes into account body size. Um, grandma's not going to have the same cardiac output as some linebacker. Okay, so if you have low cardiac output, of course, you're gonna have poor perfusion, lower blood pressure, and you'll have a compensatory increased heart rate because your heart is trying to increase its cardiac output. Cardiac output is going to be increased in early septic shock before compensatory mechanisms can really fully take place, or in hyperdynamic states. So this is when blood is moving through your body really quickly. I think Dr. Beckstrand talks about a patient she took care of who had a massive, super high cardiac output due to systemic vasodilation. Okay, formula for MAP. So one, two, three. Systolic blood pressure plus two times the diastolic. And I just remember this because diastolic is lower than systolic, so you want to make them more even, and then you divide it by three. So this is your average pressure throughout your whole vascular system. And if you have a low MAP, you're going to be at risk for ischemia. So in the ICU, like, yeah, they're looking at blood pressure, but mainly looking at MAP, and you don't want it to drop below 65, sometimes 60 or 60 to 70. Yeah. Okay. Central venous pressure. So this is the pressure sending blood. This is in your like vena cava to your right atrium. And if you think about it, um, a nurse once asked me, where is like the lowest blood pressure in your body? And like a lot of people, and I think I made the same mistake, to be honest, would like point at your toe and be like, oh, that's the furthest away from my heart, so therefore it must have the least amount of pressure. Well, that's not true because, right, that's like the middle of your system, thinking as your of your system as a whole. So you have the arteries that go down, and then the veins are going to have the lower pressure, and then the lowest would be your veins closest to your heart and going into your right atrium. Okay, so if you have decreased CVP, that's going to be because you're hypovolemic. So it's not as much a thing with like, it doesn't have as much to do with vasoconstriction because your veins don't necessarily constrict that much, but it just means there's less fluid inside your veins, causing less pressure that's driving that fluid back to your heart. If you have high CVP, then you're going to be in fluid overload. So that's the opposite. Um, and you're likely your right ventricle is failing, causing that fluid to back up into your venous system. So pulmonary artery occlusive pressure, commonly called wedge pressure. And if you remember from your packet, this is measured oftentimes with the Swan scans catheter. And this is the left ventricular preload. So this is the amount of uh, pressure that's driving blood into the left side of your heart. So it's going to be decreased in hypovolemia, same concept as before, increased with left ventricular failure or pulmonary congestion, same concept. Okay, pulmonary artery pressure, it's kind of like so wedge pressure is measured like in one instance, kind of where the diastolic here is. But pulmonary artery is just like a constant measurement, whether you're in systole or diastole. Um, so this is 25 over 10 on average, right? Because your pulmonary system doesn't need as much pressure in order to maintain perfusion, and your right ventricle is a weaker pump than your left ventricle. Um, yeah. Okay. So systemic vascular resistance. This is resistance to blood leaving your left side of your heart, and it's going to be way higher than your pulmonary vascular resistance, right? Because your systemic vasculature is much larger than your pulmonary. Um, so if you have increased SVR, that means vasoconstriction. That's right. So cold, pale skin, blood's not getting there as much. Vasodilation, warm, flush skin. Okay. This is the saturation of oxygen in your plasma that's dissolved. So if you have low SvO2, right, that means that the tissues must be taking more oxygen out of your bloodstream. So either it's like low cardiac output, hypoxia, your cell, less blood is going back to your heart to get reoxygenated. So it's having to keep on having to keep on use the oxygen that's already in your blood. And this is why CPR works, right? Because even if you're not breathing, um, as long as you can get the heart to pump, not all of the oxygen that's dissolved into your plasma is used on the first go around. So you can keep blood pumping the blood in temporarily throughout your body and letting that oxygen take letting the cells take more oxygen. So if you have an increased SvO2, right, that must mean that some of your tissue is not seeing that blood, so it's not able to take that oxygen. Okay, hemodynamic patterns. There's two charts in here. I would highly recommend for the test going through each one of these and just being able to explain why it is that these values are the way that they are. That'd be very helpful for the test. And I think I already talked about most of those. So, okay, case application. Your map of 58, low. Central venous pressure is low. Wedge pressure is low. Cardiac output, kind of normal. SVR is high. So you have a low preload, right? Because you have that low central venous pressure and the low wedge, and a high afterload. So what's going to be happening here? Hypovolemic shock. Because so why? Low preload because you have less fluid that's filling the heart. So that's why there's low preload. Why is there high afterload? Because of a compensatory mechanism to cause vasoconstriction, because your body is trying to maintain a blood pressure to perfuse your blood, and it's trying to compensate because you have much less fluid. So that's why there's a high SVR here. Okay, another case study. So you have a CVP of 7, wedge pressure of 24, cardiac output of 2.1, and SVR of 1600. So cardiogenic shock. So here you're going to have like the high CVP, high wedge, right? Because your heart is not pumping out the blood, so it's backing up into the system. It's backing up into that venous pressure. Venous pressure. Your cardiac output is going to be low on the lower side because it's not able to pump out as effectively. This can be caused, the most common cause is a heart attack. So it's a problem specifically with the heart muscle, um, right? Because like obstructive shock, cardiac tamponade is an example of that. It is inhibiting the heart from pumping, but is not an issue with the heart muscle itself. So the heart muscle itself is cardiogenic shock. Okay. And then your systemic vascular resistance is normal. No, sorry, it's a little high. Forgot the number for a second. So that's going to be a little bit high. Um, right, not as high as hypovolemic shock, but it's still compensating, right? Because you're not pumping out as much fluid and needs to maintain that blood pressure. Okay, shock. Okay, inadequate tissue perfusion, cellular hypoxia, organ failure. Hopefully that all makes sense. That's the definition of shock. So what's the cause? So we've already been talking about this a little bit. So it can be caused from volume loss, hypovolemic, pump failure, cardiogenic, and vasodilation, distributive, and obstructive is another one too. So all shock types, you're gonna have decreased MAP and decreased tissue oxygenation. You want to know what's causing it. So you have the different stages. In general, initially are going to have a decreased MAP, and your cells are going to start switching that anaerobic metabolism, creating that lactate. Compensatory mechanism, your sympathetic nervous system is going to activate. Now, in some cases, like neurogenic shock, for example, then it might not be able to do this. So you might not have an increase of heart rate. Most of the time, that's not the issue. Your body's going to be able to fix it. So you have an increase of heart rate, vasoconstriction, RAS system, right? It's trying to maintain that blood pressure, hold on to the fluid. Progressive stage, you're having a decreased perfusion to vital organs. Things are getting really bad. Lactic acidosis, decreased urine output because you're not perfusing the kidneys. And then final stage, irreversible cell organ damage. Okay, assessment of shock, kind of the same thing we were just talking about. Cool, clammy, pale skin, except septic neurogenic, may warm. So, probably a couple different causes of this, but if you think about like septic neurogenic, that's like major vasodilation is the cause. And so when you have that vasodilation, at least at first, the blood is going to pool in your periphery, and that can keep it warm for a little bit. Vasoconstriction would cause the cool, clammy, pale skin. It also is probably related to sympathetic nervous system activation. Might have some Fever might affect that too. Anyways, a couple different causes. Okay, altered level of consciousness, right? Because you're not producing the brain as much. Same thing with anxiety, confusion, and you'll have lactic acidosis due to anaerobic metabolism. Hypovolemic shock. Okay, so can be caused from a few different things. Um, Loss of fluid, and I think in your packet too, it also talks about absolute versus relative. And this gets a little bit confusing with, okay, then what's the difference between hypovolemic shock and distributive shock? I'm not going to get into the weeds with that. Um, but just know that uh, here, all of these things are talking about absolute hypovolemic shock. Um, so you have a decreased preload because you have less fluid, decreased cardiac output because you have less fluid to pump out, and you'll have an increased systemic vascular resistance due to vasoconstriction. That's a compensatory mechanism. Symptoms, you're going to be tachycardia, hypotension, cool clammy skin. Hopefully that all makes sense. You're going to treat it with fluids, right? Because fluids is the issue. So if they don't have fluids, then you're going to want to get fluids. Stop the source of loss, give them oxygen, so at least the blood that they do have has as much oxygen as possible, and they can do that tissue respiration. Okay, cardiogenic shock. So pump failure. This is what we talked about before. MI, cardiomyopathy, dysrhythmia. This is an issue with the heart itself, the heart muscle. Increase in these preloads as fluid backs up, a decrease in cardiac output because your muscle is not contracting like it should, an increase in systemic vascular resistance to try to maintain pressure. Symptoms might be pulmonary crackles as the um, as the blood is backing up. It can cause this pulmonary edema, the fluid to leak out into the lungs. An S3 gallop, which has to do with like, the sloshing of the blood in the heart. Weak pulses, chest pain. So here you want to help the heart pump. So dobutamine is a drug that helps the heart pump. Diuretics, get rid of some of the fluid. Cautious fluids, yeah, you just want to be careful with that because fluids can make these issues worse. So, okay, distributive shock. So this is characterized by massive vasodilation, decrease in systemic vascular resistance. This includes a couple different kinds of shocks. Septic, right? Um, you have the bacterial infection um, leading to bacteremia, and then you go into sepsis, which is like that inflammatory response, and then septic shock is like the worst version of sepsis. So like sepsis has digressed into, I think that's the right word. Okay, you know what I'm talking about. It is gone to septic shock. Anaphylaxis is an overreaction, same like systemic response. Neurogenic, when your sympathetic bundle is damaged for some reason, and so you're not able to maintain that tone in your blood vessels. So cardiac output is maybe high in early sepsis, so or low in late stage. So this has to do with this complicated um, back and forth between you have the arteries and the veins. So if you're vasodilated, like in one on one hand, your cardiac output is gonna from like the arterial side, your cardiac output is gonna be really high because the SVR is so low. And on the other hand, your cardiac output is going to be low because vasodilation also affects your veins. And if your veins are vasodilated, not as much blood is reaching back to the heart. So this back and forth, and you can kind of sort it out by thinking what happens like initially and then what happens later. So initially, the vasodilation is mainly like an arterial thing. And so the veins can maintain their tone for longer. And so because of that, massive vasodilation in the arteries, your cardiac output is going to be really high because you're still getting the blood back to the heart, but you can pump even more out, decrease in resistance. But in the late stage, then that's when you're going to have less preload because less of the blood is going back to the heart, and then that's when cardiac output will be low. Skin often warm and flushed early on. We talked about that. Okay, septic shock. We talked about this. Lactate is above 2. You're going to want to test that again. Tissue hypoperfusion. Okay, this is 1 hour sepsis bundle. So you want to measure the lactate. As I just said, remeasure if it's greater than 2 millimoles per liter. Then you want to obtain blood cultures before you give the antibiotic. So you obtain the blood culture because the antibiotic could mess with the blood culture, right? Then you give the crystalloids if hypotensive, or lactate is above or equal to 4, right? Get perfusion to those kidneys, dilute it a little bit, um, get perfusion to the rest of the body, and then apply vasopressors if MAP is less than 65. The main vasopressor you're going to give is norepinephrine. Uh, hey. Neurogenic shock. So a spinal cord injury, we talked about this loss of sympathetic tone. So the unique one right here is decrease in heart rate, right? Because normally your heart rate is going to increase, compensate. Here it cannot because there's damage to that sympathetic system. Okay, anaphylactic shock, epi, right? I think we all know that. Corticosteroids, those allow your cells to maintain responsivity to the epinephrine. Antihistamines to decrease that systemic response. Airway management, right? Because it can close up. Give fluids to maintain blood pressure. Okay, same thing with this chart. I'd go over it. I feel like I've said all of this. So, okay, mods is really bad. Okay, quiz time. A patient's calcium is low. What should you check? So, what other low value would cause calcium to be like low, but relatively the amount of usable calcium is normal? Answer is albumin. So check albumin, right? The most important calcium is the ionized calcium because that's the kind that's usable. So if you have a low albumin, you might have a falsely low calcium. What is the calculation for MAP? 1, 2, 3, remember? So systolic plus 2 times diastolic divided by 3. You give fluids to a hypotensive patient, SVP increases. Makes sense, but MAP doesn't. What does this indicate? So if MAP doesn't increase, and the blood is backing up into the venous system, must be a problem with the pump, which is what kind of issue? Pump issue, cardiogenic. During which stage is shock irreversible? It's just a memorization one, stage 4, refractory. After giving fluids, patient's lactate decreases from 6 to 2. What does this indicate? Pretty much that like they're responding to fluids, right? Um, so probably a hypovolemia issue. What is the most abundant ion in the body? So important, this isn't just asking what's the most abundant ion in the blood. It's saying in the body. So calcium. Think about all the calcium that's in your bones, in your teeth. Um, I don't know this for sure. I think sodium, though, is the most abundant ion in the blood, but okay. You're treating a patient with low potassium using the potassium replacement protocol. The patient's potassium continues to be low despite treatment. What other lab value would be important to check in this scenario? Okay, so this is an ion that's important related to potassium for a couple different reasons. One, this ion is important cofactor for ATP production, and ATP is necessary for the sodium potassium pump. So if you don't have this ion that we're going to be talking about, then your sodium potassium pump is not working. That means you're not going to be able to have as much potassium inside your cells. You have more in the blood, more flushing out through your urine, and so you won't have that like stabilizing reserve of potassium in your cells. Another reason why this ion is important is because it kind of acts like a plug in your kidneys. Pretty much if you don't have very much of this ion, then you're just going to pee out a lot more potassium than you want to. The answer is magnesium. Okay. Identify the type of shocks based on these values. Okay, so you have a CVP of 6, which is a little bit high, right? Because CVP is 2.5. And then wedge pressure is 17, so also high. SVR is high, cardiac output is low. Okay, so what are we thinking here? I think it's cardiogenic. Okay, cardiogenic shock. All values are high except for cardiac output. Identify the type of shock based on these values. The CVP is going to be low. Your wedge pressure is going to be low. Systemic vascular resistance is high. Cardiac output is normal. What do you think? I'm thinking hypovolemic. Okay, hypovolemic shock. And if the reason why this is true is not making sense, go over these slides again, reach out to me. Um, it does, I promise it does make sense. It just takes a little bit to kind of be able to envision what's going on inside the body. All right. Okay. I'm just gonna let you guys think through this one on your own. So you can pause the video if you need to. Answer is septic shock. Cardiac output is high in early septic shock, right? Late septic shock, then your veins also will lose their tone. Okay. All right. Please reach out if you have any questions. I'm here to help, and good luck with the test.